Good evening to all of you. It's a great pleasure on behalf of Translumina. We take this opportunity to welcome you all to this wonderful bouquet of program called Complex Made Simpler. Why this program has been made to re-christian it into a complex made simpler. So the idea was that as the world moves towards from a wire, balloon, and stent, now as we move towards a complex cases in PCI and with more precision PCI, I think the time has come, the idea has come that where we need to get more and more complex cases. And the whole idea of this program is to see that we create a platform in collaboration with the clinicians like all of you to create a platform of learning and sharing, which makes your fight and facilitate this program to facilitate more learning amongst your colleagues so that more and more people get equipped with how to tackle those difficult cases. The whole idea, this is a platform, this is a series which will happen weekly from the House of Translumina because of its collaborations with some of the finest technology world over. In fact, today, very proud to share with you, today we have waged a war against calcium and CABG both. So therefore, in order to fight this war and make things simpler, we created a program called Complex Made Simpler. This is the first of its kind which is going to happen. But before we enter, I thought to have a very small sneak peek into what does and who we are as a Translumina as a company. Some of you are well known to what we are. We had a very humble beginning in 2010 with a great strategic partnership with some of the greatest companies in the world, because we always believed that innovation without an access is not a truly innovation. So therefore, by partnering with a strategic partnership with some of the greatest organizations like Shockwave, Abiomed, Asahi made this possible, and all our products has been known to have GMP and GLP certified, and we have our footprints in more than 50 countries and our collaborations with German Art Center. And very proud to share that we are the only company in the world today that we have the RCT data of 10 years of back-to-back of both a polymer and a polymer-free stents both. And that is why today we are poising to create a situation that where we can make a world of polymer-free angioplasty in times to come. And in order to do this, I am very, very privileged to introduce the moderator of the evening, Dr. Nikhil Kumar, sir, who is presently a director of cardiology at Fortis Memorial Research Center at Gurugram. And he has been a cardiologist with extensive experience in the field of interventions, non-invasive, preventing, clinical cardiology to name. He had a wide range of academic, administrative, and a professional experience. He has been a versatile genius and as a professor, head of the cardiology department in hospital research and referral center in Delhi. And sir would be taking this evening forward with what of great faculty which has come today evening. Had it been again, I keep on repeating that had it been a face-to-face, I can assure you getting this individual, such a great expert, would have been very, very difficult. But thanks to this technology, which has really made things simpler, to bring the entire esteemed panelists and chairpersons of the evening, who are a very well-read, great academicians who comes together and talks and shares their learning to make this learning much more important and valuable to many who is listening to large number of audience today. They are spending time and learning. So over to you, Nikhil, sir, for taking this evening forward, sir.
Yeah, thank you so much. And San, I think you've introduced the evening on the right kind of note, and I think you'll be ready to launch. So let me just share my screen and I'll give you the flow for the evening. So like you said, that we would be trying to make the complex much simpler by use of all the amazing hardware in our armamentarium, thanks to Translumina. And One sec. Yeah, so the agenda for today would be a small, presentation which I will give to set the stage, and then we have three case presentations. We have a very, very eminent list of chairpersons, panelists. So let me welcome you all. Dr. Pramod Kumar, Director and HOD, Medanta Hospital, Patna. Dr. Debdatta Majumdar, he's a Senior Intervention Cardiologist at the NH Rabindranath Tagore Institute of Cardiology in Kolkata. We have the co-chairs, Dr. Dilip Kumar, Director of Cath Lab and Senior Intervention Cardiologist at the Medica Superspeciality Hospital in Kolkata. Dr. Mahendra Prasad Tripathy, the Clinical Director and HOD Care Hospital Speciality, Bhubaneswar. The case presenters, the true batsman of today, Dr. Brajesh Kumar, the Senior Interventional Cardiologist at the Director Head of Cardiology at the Fortis Hiranandani Hospital in Vashi. Dr. Arshad, Director Cath Lab Services and Senior Consultant Cardiologist at the SK Hospital, Trivandrum. Dr. Sachin Battle, Interventional Cardiologist at the Sachin Superspeciality Hospital in Kolhapur. The eminent panelists I would be, give me pleasure to introduce are Dr. Randeep K. N. Shivam, Interventional Cardiologist, Apollo Hospital, Guwahati. Dr. Subhasis Roy Chaudhary, Interventional Cardiologist at the AMRI, Salt Lake, Calcutta. I keep going back to saying Calcutta because I had a very pleasant stay in Calcutta long ago. And so Dr. Sushant Kumar Pathak, Interventional Cardiologist at the Ford Hospital, Patna. Dr. Shailendra Trivedi, HOD at the Vishesh Upeta Hospital, Indore. Dr. Arijit Ghosh, Senior Interventional Cardiologist at the AMRI, Salt Lake, Kolkata. Dr. Akhilesh Jain, Senior Interventional Cardiologist at the Apollo Rajshri Hospital in Indore. Dr. Pranay Jain, Interventional Cardiologist at the Ramakrishna Care Hospital, Raipur. And Dr. M.V. Reddy, Senior Intervention Cardiologist, Western Railway Hospital in Mumbai. We have Dr. Sunandan Sikdar, Intervention Cardiologist at Narayana Multispeciality Hospital, Kolkata. Dr. Amitava Misra, Interventional Cardiologist at the Apollo Excel Care, Guwahati. Dr. Dilip Tiwari, Intervention Cardiologist at the Metro Prime Hospital, Jabalpur. And Dr. Ashish Tiwari is the Intervention Cardiologist at the Shalby Hospital, Jabalpur. So my introduction went without the pictures.
Yes, sir. Yes, sir. I thought
you should have interrupted me. I didn't know. I was, I think, busy listening to my own voice. So today we'll talk. I'll give you a brief overview about the polymer-free stents and experience in diabetic patient subsets, and this will set the stage for our further deliberations on the subject. And I apologize. I think goofed up with my last slide set, which showed the panelists and the chairpersons. And so anyway. So diabetes, one we all know, is itself a major risk factor for coronary artery disease. And these diabetic patient subsets, they are different from the usual, routine patients with coronary artery disease because of this complex interplay of dyslipidemia, hyperglycemia, hypertension, clotting abnormalities through the pathway of endothelial dysfunction. Contribute to accelerated coronary artery disease. So these patients with diabetes have smaller size vessels. They have complex anatomies with a higher incidence of multi-vessel disease. They have locations of lesions in areas with subtend large areas of myocardium. That means the proximal segments, the left main disease. The types of lesions are more complex with CTOs and more incidence of bifurcation lesions. They have impaired collateral circulations and a higher incidence of coronary artery calcification. So this would be pretty obvious to everybody that these patients present a much more complex subset and more difficult lesions to treat, and patients with higher rates of clinical events. So having said that, what are the current challenges with polymer-based DES? One is very, I'm sure everybody is aware of this. We've been through the entire range of, all of us have seen the first generation DES, the issues with the initial sirolimus eluting stents, which came up with big promise, and then because of possibly the polymer, resulted in, a higher incidence of chronic inflammation, persistent platelet activation, persistent fibrin deposition, delayed endothelialization, and this all resulted also in malappositions and prothrombogenicity. So they were associated with there was polymer flaking, peeling, webbing, which again impaired with the action of the drug. So we did consider them as an essential evil in the composition of a drug-eluting stent. And there's enough data available. I mean, these are very, very old articles, but a lot of data available, and our clinical experience also tells us that we did have a lot of polymer with all types of polymer in the first and second generation stents. Now, Propofol was shown to be effective in reducing the rates of restenosis after coronary angioplasty. It's a highly lipophilic substance, and it slows down the release kinetic of the drug which needs to be eluted in a drug-eluting stent. So based on this, we have a stent called the VIVO ISAR, and So one would expect a faster release because of no polymer, and this would obviously compromise the DS ability to prevent smooth cell proliferation for the complete 4 weeks, hence an increased chance of restenosis. But what we see is different. With this dual drug polymer free, the VIVO ISAR, besides not having a polymer, demonstrated, as is obvious with this graph, optimal drug release kinetics with prolonged release of sirolimus, which is 80% in 28 days. So this was very similar to a stent with a permanent polymer-based technology. In preclinical trials, it was seen that sirolimus and propofol are released in 4 to 6 weeks, and the world's first dual drug polymer drug-eluting stent, the VIVO ISAR, defined technology which was refined over the years. It has a microporous surface which helps in controlling the release kinetics of the drug. It has a low closing profile, so your deliverability is much better. You have an abluminal coating of the drug, leading to a faster endothelization, and a hybrid design which optimizes side branch access. And of course, it has low strut thickness, but without compromising the radial strength. So these are technical specifications. The basic material is a cobalt chromium alloy platform. It is a modular multicellular design available in a variety of lengths, diameters. And like I mentioned, it has a surface modification in the micropores. It has a favorable strut thickness and width, with a very favorable metal artery ratio, good radial strength, and a good strength profile. Now, it is supported by about 10 years of data of clinical efficacy and safety. Now, when we do a procedure, we are both interested in the efficacy of the procedure and safety of the procedure. So, the first data from 2004, it was found that microporous surfaces were found to be equally safe as compared to electropolished surfaces. 2008, in a preclinical study, the VIVO ISAR demonstrated ideal drug release kinetics, like I showed before, and better endothelization as compared to polymer-based and conventional polymer-free stents. 2010, at 2 years, VIVO ISAR demonstrated a 33% reduction in binary restenosis as compared to the Endeavour Sprint, and a 25% reduction as compared to the Cypher. 2016, with 5 years, VIVO ISAR with no polymer demonstrated similar rates of definite or probable stent thrombosis as a permanent polymer, zotarolimous eluting stent. 2016, at 5 years, the patients treated with the VIVO ISAR compared with the durable polymer-based Zataraolimus eluting stent was similar in a subgroup of diabetes. 2017 presented in the Sky 5-year outcomes of patients treated with the VIVO ISAR compared with durable polymer-based Zataraolimus eluting stent was similar in the subgroup of STEMI. 2019 with the results of the ISAR test 5. Now, this was a long-term analysis at 10 years. The polymer-free VIVO ISAR showed less with similar efficacy and good safety profile as the Resolute Integrity. And 2021, with this 10-year follow-up, which we're going to discuss today, in diabetic patients, we saw numerically lower rates of all-cause mortality, notably low rates of target vessel-related myocardial infarction, and low rates of definite stent thrombosis at 10 years follow-up. Now, this is very, very robust data which is available. So this VIVO ISAR, the 10 years clinical data and efficacy study was a randomized trial of polymer-free sirolimus and Probicol, that's a dual drug eluting stent, versus the polymer, permanent polymers or tacrolimus eluting stent in patients with coronary artery disease. And 3,002 patients were enrolled and randomized, follow-up over 10 years. The primary endpoints was device-oriented composite endpoints of cardiac death, target vessel related myocardial infarction, and target lesion revascularization. The secondary endpoints were the patient-oriented composite endpoints of all-cause death, any myocardial infarction, or any revascularization, and definite or probable stent thrombosis. So we saw a low rate of stent thrombosis, 1.6% with VIVO ISAR at 10 years. So this was not statistically different from the Zataraolimus, though numerically lower, but not statistically different from the Zataraolimus eluting stent. Showed that the clinical outcomes in 10 years in patients of polymer-free versus durable polymer DS were comparable. Now, a very long outcomes data with diabetic patients with coronary artery disease undergoing PCI with the durable polymers of tacrolimus eluting stent versus the polymer-free sirolimus and Probicol eluting stents. So this was again the patients were randomized to a new generation polymer-free sirolimus Probicol eluting stent, which is the VIVO ISAR, and the new generation durable polymers of tacrolimus eluting stent, referred to as DPS. Patients were with diabetes and without diabetes in both the groups, and a 10-year clinical follow-up studied for primary and secondary endpoints. So it showed that we had, with the 10-year follow-up, the VIVO ISAR with diabetes mellitus versus a Resolute in patients with diabetes mellitus, there was numerically lower incidences of, though not significant incidence of all-cause death, cardiac death, any revascularization, target lesion revascularization, and target vessel-related myocardial infarction. The MACE and all-cause mortality at 10 years in diabetic patients were numerically lower with the VIVO ISAR in the diabetic subset. So in both, so this is on the left side, you had the durable polymers S in patients without diabetes, the durable polymers S in patients with diabetes, the polymer-free sirolimus eluting stents without diabetes, and the polymer-free sirolimus eluting stents with diabetes. And it was shown that the numerically lower rate of VIVO ISAR was seen in the diabetic subsets, and a notably lower rate of target vessel-related myocardial infarction, though not clinically significant, was numerically 33% lower in patients with the VIVO ISAR. So to summarize the whole data, we see that the VIVO ISAR is obviously the first DS in the world with 10 years follow-up data in the diabetic subset. The study was conducted against a FDA-approved DES in diabetic patients. Outcomes were published in the Clinical Research Cardiology 2021, and it demonstrated a low rate of stent thrombosis in patients with diabetes mellitus, a lower rate of target vessel-related myocardial infarction, and a numerically low rate of MACE and all-cause mortality in the diabetic subset. So it's a stent which is well suited for treatment of coronary artery disease in diabetic patients. Thank you for your attention. So I think Dr. Arshad is there with the first case. Are we ready with the first case?
Actually, Dr. Brajesh has a case.
Okay.
He has requested to have his presentation first. So kindly accommodate, sir.
Sure, please. So may I request Dr. Brajesh to go ahead with this presentation?
So this was a 63-year-old interval of mine who was not thrombolized and was admitted in our ICU. Can you hear me?
Yes, sir, we can hear you.
So this patient has a rest angina and he was requiring inotrope with some fine basal crepes. So with rest angina, even though the window period was almost 24 hours to 36 hours, but he was in a cardiac shock and pulmonary edema. So we thought we will see what is the anatomy, and we took this patient. So this was the angiogram to start with. You can see the LED was occluded. There was a big diagonal which was arising just before the occlusion. So we started this case with a routine O3 routine coronary wire. We thought it's an acute MI, it can easily be crossed, and we can see some filling of LED in the late phase. So post wiring, the wire went very smoothly and the lesion was dilated. And then suddenly we realized that the patient started having hypotension and there was a leaking of contrast from the coronaries. So at this time, we immediately started looking for the echo machines to look for what is happening. And since I was the only single operator and there was no other cardiologist available, I have to do both the work, and the patient was already on inotropes. It did not give us time to resuscitate. So in one hand, starting a putting a needle in the pericardium, and the other hand to just localize where is the block, where is the perforation, and go for a stent graft. So finally we put a stent graft there, and and proximally again I put, since I had only one stent graft available, I put another stent proximally. So the stent graft was 318. So just trying to localize where was the rupture. I just stented with two, and then meanwhile continue to put a pigtail and started aspirating. Patient was a bit down with inotrope support increasing, the cardiac contractibility also less, and then finally after seeing all those things, wire was also coming out. Finally did completely, the complete LED was stented except the distal part, and the flow became TB3 flow in the LED, and it seems that the perforation is sealed off. Now at this point, what happened is I realized the patient is not improving much. Even though the filling of pericardium was less, but the filling continued. I mean, the pericardium continued to fill with blood, and I started thinking, are we missing something? So this view, no, I was thinking, why did this happen? I mean, this thought process was going in my mind. Why exactly this has happened? I mean, see, my wire seems to be going into the lumen, and I have not dilated with a very big balloon. It was a 2 mm balloon. So what exactly has happened? So I realized in this first view that probably my wire went parallelly into a septal which was going in a parallel direction along with the LED. And in spite of sealing off the perforation with the stent graft, it continued to be bleeding from that septal. Now the thinking was, why a septal perforation will cause a pericardial effusion? It should not cause a pericardial effusion. Septal should not cause a pericardial effusion. Then I thought, what else could be the reason? So meanwhile, I thought maybe the perforation will stop. Let's activate these surgeons to come and help us. I mean, finding out what is happening and all. But finally, I decided I feel the septal, something else is happening in that. What is, I just wired the septal, and meanwhile, the LED wire also came out. In the same wire, I put it in the septal, dilated the ostium of the septal a bit, wired it, and then put a micro catheter and just sealed off the septal with the coils. Now, at this point, that septal probably was responsible for the pericardial effusion. May not be the real septal, but maybe the point where the septal arises from an epicardial artery, epicardial coronary artery, before it goes into the myocardium. Probably that point may have got ruptured because of the balloon. That is what I thought of, because after this, I waited for almost 45 minutes. I completed the LED down. Also, there was a lesion. I just went and completed the rest of the LED, and then things becomes very smooth. Patient immediately improved, and on table the requirement for inotropes were almost over. Left the pigtail for some time to look for maybe bleeding, but once we aspirated it, nothing came out after that. And pigtail was removed the next day, and patient was absolutely stable following. I just thought a rare case where, I was also not sure whether if perforation was did happen at the junction where the septal arises from an epicardial coronary artery, that might have got ruptured, and the coils which I just put just near the origin of near the septal where it arises from the LED, probably that would have thrombosed the perforation. But whatever it is, I was successful in sorting out this, and the patient improved. So, a case of coronary perforation, probably the friable myocardium was responsible for that. On top of that, window period of more than 24 hours. That was one thing, and probably a micro catheter before, doing a balloon dilatation would have helped. But in a situation like a palmy situation, how many times we take a micro catheter? That's also a bit this thing. So the case which seems to be a simple one, wire, balloon, thrombosuction, do this, that, do. So was got complicated, and lucky save we could manage. So I felt, I don't know what has saved us, is the coils which has saved us, or is the stent graft which has saved us. But yes, the patient immediately improved, and in fact it did not require blood transfusion. We did some auto transfusion on the table. We took a help of all nursing team which was available, and I will invite everyone to have an opinion.
Yeah, I think it was so brave of you, Dr. Brajesh, to show this case to all of us. And Professor Dr. Nikhil Kumar, your comments, then I will ask question.
Yeah, can you stop slide sharing?
Yes, sir. I thought if somebody wants to see it again.
Yeah, okay. I'm so sorry. No, I think it was a complication very well handled. Did you use a thrombosuction when you initially wired?
No, sir. No, sir. We did not use.
Any particular reason you don't use thrombosuction?
Sir, actually, we thought patient was on Clexane for almost 24 hours. He already received 2 doses of Clexane. We thought thrombus may not be much, And that is why we thought, let's dilate it if we find that there's a lot of clot and all. That's why we took a low profile 2 mm balloon, not with the 2.5. So probably thrombosuction also, thromboster might have also gone in the same direction as the balloon vented, because we did not feel any obstruction. It just vented smoothly. I think the friable myocardium was the one responsible.
No, no doubt about that. Can we have some comments from the chairpersons, co-chairpersons?
Sir, Brajesh, nicely done, Dr. Reddy here. But only my concern is any preparation, anything is first to identify the site, very important.
Yes.
Because not to jump into the stent everywhere. Because if you identified the site, exactly targeted that site, you must have saved so many devices using it unnecessarily. That is one. Probably when it is a CTO, inadvertently you must have handled the wire, must have perforated that site. Exactly, it has happened at the site of CTO, looks like. Because where the septal branch is also coming, you must be avoided to. So unnecessary stent graft is most would have been avoided if you would find out the site exactly.
Case, this was not a CTO.
No, it is total. It is occlusion, acute occlusion, right? It is occlusion with a lot of tortuosity of the vessel.
And the pericardium flow was so much that only way I felt the patient can be stabilized was to seal off the perforation.
I understood in an emergency. I understood, but identifying the site is very important to target there. You would have been if identified site immediately, you would have coiled that area. Would have salvaged it immediately. Because unnecessarily stent graft and many stents putting that non-perforated area may not be a good thing.
I think point well made, Dr. Reddy. So somebody else from the chairpersons, the panelists, anybody would like to comment?
Yeah, I have 2 points to make. Like many situations when you are doing intervening in a patient who has 24, 48 hours, maybe 2-3 days of MI, and then you go on to carry on, you go on to stent the patient. Many times this patient has an ongoing inflammation, transmural infarction, and then there is always a Uji, myocardium. And when you give 8 to 10,000 of heparin, so I have seen in 2-3 cases which are very clean-cut cases, and then patient had a pericardial effusion, and 1 or 2 patients required pericardiocentesis, 1 or 2, and many patients recovered. As usual, just we watched and some minor drops and some fluid. So this is after 2-3 days of MI we have seen, but this case we couldn't localize, and I didn't see anywhere where the dye contrast was going into pericardium. So what exactly happened?
I felt that it was not a perforation. It was just a rupture, and it was very, very difficult to localize it. I did wasted some time in positioning my graft, stent graft, where to position. The way in which the pericardium was getting filled, the amount of blood which was coming from pericardium was huge. So, and being a single operator, no other cardiologist available. So, it was like saving the life of a patient. So, I think
one point which when you're wiring a vessel which is totally occluded, if you take okay, the wire is going down in the general direction, but if you take a couple of different views without injecting contrast, also you can make out, okay, the vessel is going, the wire is going to a septal or going into a diagonal, but just by the direction of the wire. I think that is a very important
thing to do. If you see the septal which I have coiled runs exactly parallel to the LED.
Oh, that's in one view, right?
Yes. Even in other views also, if I have shown you 2-3 views. I've seen a PA cranial, I've shown you LO cranial also. So even in both that views also, if you see the septal which I've coiled runs absolutely parallel to it. If I want, I will run it again. So that was the one. See, when you have a doubt that your wire is not going nicely or the wire is in some branch, you take multiple views. In fact, I would have taken a micro catheter to check where exactly I am before injecting a contrast, before doing a balloon dilatation. But the line in which the wire went was exactly parallel to the LED. And in this case, I'm still not sure whether what has worked, what has clicked, is the stent which has clipped or is the septal perforation which have clipped. But yes, the patient is saved.
Do we have Dr. Pramod on the panel?
Usually wire perforations will not fill the pericardium like that. You must have wrongly dilated the septal branch, looks like, but unfortunately could not able to prove that area. Because most of the
Seems
time,
more likely, yes.
yes, because wire perforations will not fill the pericardium so much rapidly. And
Wire did not perforate. The gushing started only after the balloon dilatation.
correct, you must have dilated
right.
the area which where the wire in.
Yes, I agree that it did not
Yeah.
perforate. Wire did not perforate because this was not a CTO. The wire went smoothly. There was no issue in
why,
wiring at all.
just a minute. Normally during ATO, the wires main lands in diagonal anything branches which are parallel. It's commonly happen. Why suddenly you go for dilation? Why not just daughtering the lesion and see the whether your wire is parked in a main vessel or not? It is commonly practiced that just touching the not dilating the lesion or just we go and through the balloon. So just looking the just whether it is in a true lumen or it is in a true lumen in a branch or a main vessel. That's help. That's guides quite some many times guides us in wrongly dilating the diagonal or septal. These things commonly happen, but we just daughtering help us in maximum times. That's in a tiny flow. That's guide us that now our wire is not in the two vessel patent vessel. It is in branch sometime. That's help us.
And again, the same point which I was bringing up earlier is that suppose you have a proximal vessel with a lot of thrombus. Once, I mean, I'm very certain that if you do some amount of thrombus suction, you at least get some flow into a vessel and you know where you're going. I mean, if you have that much of thrombus, it's always a good idea to, okay, data might say otherwise, but in my clinical experience, whatever it's worth, that if you have a lot of thrombus like this one, it's so obvious that it is full of thrombus. So, I mean, if you did a bit of thrombosuction, but maybe because you're in a septal, your thrombosuction catheter would not have gone through, may have indicated to you that, okay, there's something wrong. One. And then even if you remove some thrombus from the proximal vessel, you do get a trickle of flow into the distal vessel and you know where you're going.
Yes.
Yes, that is
I agree. Probably
same.
the use of thrombus might have not have created a complication. Absolutely, but
Anyway, see, it's
you
all
realize
learning.
once it happens.
Whole aim of this discussion is to see what there, and we learn from each other. And at the end of the day, that okay, if we did make a mistake, we don't do it again. So I think that is the whole point. But then at the end of the day, I think you saved the day, and I think that was very nice. Anybody else from the panel? I'm not really to show who all are there. I don't see too many. Dr. Debdatta, Majumdar?
Yeah, good evening to all of you. I was just listening to the different views put up. I think I would suggest that yes, most likely the wire might have inadvertently gone into a different vessel, as was discussed. Nothing new to add. That I would certainly prefer, as we normally do, balloon daughtering followed by with a 1.5 maybe. And then certainly a thrombosuction in 9 out of 10 patients of primary PCI that we do. I'm a strong proponent of, I mean, in contrast to what the trials might be saying, but in our patient subset, I completely agree with Dr. Kumar that certainly helps a lot in when we thrombosuction. But all said and done, it's easy to discuss here. As we rightly said, he was the only one cardiologist present. It's a nightmare situation from him. Congratulations to him that he'd been able to salvage with whatever he has done. And now we can obviously, sit on a Saturday evening and post-mortem. But again, congratulations that the patient was salvaged.
So
and we can
in all PAMIs, if there's a total occlusion, I always do a thrombosuction.
Yeah.
This was like a post 24 hours, and then the balloon which I use for dilated was going nicely inside. It was not getting obstructed.
Right.
So you use, and I'm not doing a CTO that even if many a time we might have dilated a septal with a 1.5 or 2 mm. It never ruptures. We many times dilated balloon also, diagonals also. We took this scenario. I felt the problem was a very friable myocardium. Probably at 24 hours, 36 hours. That is why the guidelines also says that think about taking a patient for a procedure once the window period is out, because it can have issues. I felt This was a case where I had issues because of the friable myocardium. Because if you have an obstruction, if you feel that the wire is not going, you will check why it is not going. If you feel that the balloon is not crossing, you may take a microcatheter and see where exactly you are. There was nothing like that. It was going in a very smooth way. And if you see the final result, this, in spite of no thrombustor used, I had a TIMI3 flow. So I felt 24 hours are already gone. Patient has been received already 2 or 3 doses of vaccine. Let's see, the thrombus load may be less. But I agree, if I have to do this case again, as sir has already said, I might have used a thrombustor. Now henceforth, any case which I do after 24 or 36 hours of MI, I have this thing in my mind. So I make sure that, before dilatation, sometimes I use a microcatheter, sometimes I do a thrombustor. So I am very, very sure. This case, if you see the direction of septal, it is almost the same as an LED. It is not coming out perpendicular to the LED in all the views. It is going parallel to the LED.
So if I were to name this case for you, I would call it the case of the red herring septal. Okay, so can we move on to the next?
What was the wire that he used? Just sorry to interrupt. What was the wire that he used?
It was routine coronary wire.
The reason I asked you, I mean, when we do a primary, opinions might vary, but generally we tend to use a run through, at least in our scenario. That is the wire we normally use. But what was the wire that you used?
I think same thing, run through wire.
Okay, I think that was a very nice case and very nice discussion. Who's ready next, Dr. Arshad or?
I can present.
Dr. Arshad is ready?
Yeah, yes.
Can we have you?
Yeah, he's ready. Yes.
Great.
Good evening, everyone. It seems my slides are visible.
It's visible, sir.
Yes, we're visible.
And before I start my presentation, I would like to give a thank you to Translumina for giving me this for accepting my case. But in fact, they have given me in the agenda. I was surprised to find that in fact it was regarding a complex case. But to me, they personally informed that it is regarding a case of a case to highlight the characteristics of their stent VIVO ISAR. So this is a case which happened to be in our day-to-day practice, not a very complex case. So this case, the slides have been already presented. These the characteristics of this stent, which we know. This is about probably the world's first dual drug polymer-free drug-eluting stent with the sirolimus and the propofol. As the propofol is acting as the release agent of the sirolimus. In fact, release kinetics of both these drugs in fact matches together, and the shellac resin, which will really form as a coating to prevent the breakage of the this drug complex while you are handling the stents during the placement, and cobalt chromium is the platform, and it has got microporous surface, and propofol is the alternative to polymer, and many studies where their polymer or a permanent polymer is deleterious to the life of the stent. So propofol is a safer solution obviating the need of polymers. It's found to be safe even at a much higher doses, and but we don't have much studies or in with the polymers in the current generation drug-eluting stents, and they are found to be pro-inflammatory also. Propofol is studied in oral drug also. It's an up to 500 milligram with a proven safety. It was previously being used as an hypolipidemic drug, but none of the excipient, which is studied or polymer, which is not studied for its safety in humans. And so there are some from the previous study, previous presentation, we know that there are some data for up to 10 years is available with this polymer free sirolimus drug-eluting stent called VIVO ISAR. So these are the characteristics of the stent and the diameter. There are small vessel diameter, medium vessel diameter, and the strut thickness is one of the lowest in the market. With the small vessel stent strut thickness is around 68 plus or minus 5 microns, and the medium vessel it has got a strut thickness of around 79 plus or minus 5 microns. It's one of the lowest in the kind which is available. And the metal to artery ratio is 9 to 14% as per the design, and the radial strength and stent profile are excellent. And as we all know, this has got a microporous surface which controls the release kinetic of the drug, the lowest crossing profile around 0.9 millimeter of the small vessel stents, and abluminal coating which will lead to faster endothelialization, and which has got a hybrid design so that it will we will have a better access to the strange and a low strut thickness in the market. One of the stent with the lowest strut thickness in the market. And this data already been presented by my previous presenter, chairperson. Okay. My case is, as I told, this is about a 76-year-old male who's a diabetic hypertensive, and this is a case which we really happen to do in our day-to-day practice. We present with the no onset angina, ECG showing RBPB, and echocardiography showing ejection fraction of 65%. These are the characteristics of the lesion. In fact, the patient has a minor LAD disease and also a circumflex disease, which is very tighter in the mid-circumflex junction and mid-circumflex area. And just after the OM, in fact, the lesion is very tighter. But when you really having a second look, you may find some plaques which is extending from the proximal segment to the OM1, and which is also there's a plaque which is beyond the tight lesion, and also it is reaching towards the OM2. So it's relatively a longer lesion, and possibly the stent and the circumflex angle with the left main is not very acute, but still it is not very obtuse. Also, it's around possibly a 70-80 degree angulation with the main vessel. And RCA, as we know, it's a non-dominant vessel and with minor vessels. So we planned for a PTCA to circumflex, and we did an IVS run for this person, and we found a relatively better landing zone in the distal circumflex. And then there's a tight lesion with so much of plaque around the mid LCX, and then coming to the lesion area, it is very tighter with the MLA very minimal. And there are some areas of calcium with this calcium also there, and this is the proximal area of the circumflex, which is very roomy. And so what is very conspicuous in this IVS is that just like our angiographic findings, there's a distal landing zone which is pretty distal to the main lesion, and the size of the vessel at that area is around 4.2 millimeter, and which is possibly larger than what we saw from the angiographic picture. And the size of the vessel, the proximal circumflex, is 5.1 millimeter. This is possibly considered as the landing zone of the proximal area. So this is a relatively longer stent with a 5.1 millimeter proximally and a 4.2 millimeter. So there's a size discrepancy of around 1 millimeter between the proximal and also the mid segment. The distal circumflex was measuring around 3.9 millimeter in the iris. And we dilated with a 2x15 NC balloon, and which is followed by a drug-eluting stent 3x32 VIVO ISAR covering the proximal segment and also the distal segments of the disease. And the stent tracking was easy, even though it was a relatively longer stent with some acute angulation between the left main and the circumflex. The stent tracking was easy. And we didn't use a wire to the OM1, as we found that the circumflex or OM1 ostium is disease-free. So we didn't use a wire to that. But as in our previous experiences, we found that in fact VIVO ISAR is a good stent to recross to the branches. In fact, all it has to be closed in a later time. And we are given a 3.510 NC balloon as per the IVS criteria. We have done a post dilatation with a 3.5 into 10 NC balloon in the distal segment. And beyond the OM, we did a post dilation with a 4.5 to 6 active force in the proximal segment. In fact, just to highlight that, in fact, as per the norms of the VIVO ISAR, and we do have the benchmark studies from the other stents or Zions and Onyx, but in the VIVO ISAR, there's a benchmark studies available. The 3.5 millimeter stent can go up to 4.5 millimeters. So 1 millimeter upsizing is allowed with a 3.5 millimeter stent. And this is the final picture of this with a 8.9 millimeter square is the MSA which we obtained at the distal area, and the proximal area has a MSA of 11.3 millimeters square. And I just want to highlight some of the characteristics of the VIVO ISAR stent, and also some areas which we look into when we are selecting it, especially a longer stent and all. And that's why in fact I have selected this case. And
I hope everyone will do it in the same way. And the case is open for discussion. Thank you.
Yeah, can I come in?
Please.
Yeah. So, yeah, please.
Dr. Arshad, what was the size of the stent that you implanted?
332.
I mean the diameter of the stent.
It's a 3.5 millimeter stent.
But I think you wrote 3.
No. It's a 3.5 millimeter stent.
Okay.
3.5 into 33.
Fine.
Yeah, the slide said 3. So
Yeah.
Oh, sorry.
I think in your slide it was 3.
That's okay. It's, I think, a typo. I think it was a nice case, and highlights the use of imaging. Because one wouldn't have expected that vessel to be a 4.5 millimeter vessel. So I think that was a good learning point here. Somebody from the panel, Dr. Sachin, we haven't heard from you. Are you?
Yeah, I think because now we have the bench testing available, we can use these stents with more confidence. And especially the good part is like 2 mm or these smaller scaffolds are also available, because I personally have been using it quite a lot. And apart from, I think it's the only Onyx, and now Abbott has come, and it's the only VIVO ISAR which is available. And it's a good high pressure, inflation. It's like if I take a 2 mm balloon, the nominal pressure is 11, and at 16 atmosphere, still the stent is 2.16. So that gives a lot of comfort in putting these, as well as now what Dr. Arshad showed about the larger diameters. Since the bench testing is available, reasonably we can expand at least more than 1 millimeter. Only I had a small doubt that is your IVS did show the distal diameter of 4.14 and then the proximal showed 5.1. And then did you thought of implanting, five balloon for a post dilatation?
Yeah, that's it. In fact, our it was 4.1 millimeter in the diseased segment, 3.8 millimeter in the distalmost circumflex, and 5.1 millimeter in the proximal circumflex. So we have gone with a 4.5 balloon and went up to 16 or 18, so it is almost 4.62 or something. And the stent expansion in the IVS was also very good, and there was no area of malapposition.
This was a dominant circ, sir.
Yeah.
I mean, it's surprisingly such a big size. I have not seen so far.
That's what I mentioned. I said it was a clear learning experience from. we have somebody from the panelists who would like to make a comment?
Because probably I would have landed up in using a 3 millimeter stent.
It would have been undersized.
Do we have anybody from the panelists or co-chairs who would like to say something?
Sir, Dr. Pranay from Raipur. Looking at the imaging, without imaging, if I would have done this case, I would have taken at the max 3.0 stent and pot with 3.5 at the max. So the IVAS definitely changed from 3.5 and 4.5 pot. So if I would have done without imaging, definitely the patient would have come back with ISR.
So, Dr. Arshad, do you do imaging routinely in all of your cases? What prompted you to do an imaging in this particular case? Any thoughts on that?
After seeing such kind of cases in our day-to-day practice, in fact, at least for 50 to 60% of the cases, we have started doing. Our research is a moderate center, so in fact, you do have the luxury of time to do the cases with the IVAS.
Dr. Dilip? Dr. Dilip, you have any comments?
I think all the dominant vessels, either RC or LCX, I think imaging is a must, I think, because they supply quite a large part of the myocardium. Any compromise in optimization can have a deleterious effects on the patient outcome.
I think it won't be an overstatement here if I may say that there would be a day when imaging would be obligatory whenever we are doing a PTC, because it gives us a lot of insight into what we are dealing with, and certainly translates into much better long-term outcome.
Yes.
Yeah, I think it was a wonderful case, Dr. Arshad. Just a word of precaution from my side. I was always a little bit overestimate the vessel. So you have to have a kind of a judgment, not to go something like 5 it's showing and then circumflex your visual appearance on angiogram, you take a 5 balloon and then blow up. So maybe a balance needs to be, struck. And OCT gives a better correlation and exact sizing. And I was maybe 8 to 10% in different studies they have shown. So yeah.
Yeah, so
as also by at least by 0.25 millimeter.
Yeah.
I think if you take this one media to media, I think you can downsize. If you take lumen, I think you can size it 1:1.
Yeah.
Yes.
When regarding EM to EM, so a lot of US operators, they take EM to EM, but I have seen Europeans taking mainly media to media. But lumen to lumen is not recommended as such, but definitely it's a better guide.
Yes.
But we never expect LCX of 5 mm diameter actually.
Right.
It's really a great case. Thank you.
Yeah. So thank you, Dr. Arshad, for this, insightful kind of a case, and the highlights the use of imaging for sizing your stents, for optimizing your stent expansions, and I'm sure what we've learned is that, of course, a good acute result, will result in a good long-term result. So thank you so much. And next presenter would be Dr. Sachin Battle. Are you ready, sir?
Yes, I'm ready. Okay, is my slides visible? Yes. Yes.
Yes, sir.
Yes. So the today's topic for this will be undilatable and uncrossable lesion. So I'll be presenting a case for that. So I have a 73-year-old male who is diabetic and hypertensive. Bypass was done right in 2001, where 3 grafts were implanted: Lima to LAD, RA to PDA, and SVG to OM1. And now after so many years, he is back with angina, which was very classical, and treadmill test was positive. So this was the good record keeping, 20 years he kept it very properly. So this shows the RCA, which has a proximal 50% lesion and 100% CTO in the mid segment with the bridging collaterals, and a distal 70% lesion, which was filling from these bridging collaterals, while on the left side there was OM and LAD. So rightly, because of the diabetes triple vessel disease, and that point of time he was sent for surgery, and he enjoyed the fruits for it for 20 years. So this is the case, which shows the left system, which has a triple vessel disease. So this is the right coronary, which has again the same picture what has been drawn right at the beginning. So just a second. Yeah, I need to freeze it. Yeah, this was the case, which showed right, similar to what it was. A proximal around 50 lesion, mid-segment CTO, and distal is not visualized. But what we can see very clearly is the significant calcium, which is there. This is the area view just to highlight that this is a CTO ending in a branch, which is a significant major branch, and the distal lumen is not well seen, but we can see that there is a heavy calcium at the distal as well as in the proximal segment. So here now let's see what's the graft situation. So here we are probably dealing with a calcified CTO where the lesion length is more than 20 millimeters. This is a SVG to PDA graft, which has a disease in the proximal segment. The mid segment or the body is fairly okay till the distal. There again, it has got a very narrow and then ending in a PDA at a disease segment. So now both the other grafts are functioning. So OM is functioning, Lima is functioning. So his cause of angina is this dominant RCA, because graft is not fine and the native is obviously CTO. So the issue was now how to approach this, because it's a 2-decade-old CTO, and JCTO score, if we analyze, it's a blunt stump with a significant side branch. Calcification very obvious, calcium length more than 20 millimeters. So category is very difficult, and the success rate is probably only 50% as per this. So whatever it is, but there was now the issue is antegrade versus retrograde. So antegrade was selected by me. Retrograde was not possible because the graft itself is very bad. It's a diseased graft, as we can see here, and as well as in the distal segment, plus ending in a PDA segment and then going back into the RCA would have been very difficult. So this is a simultaneous injection showing the RCA. Okay, let me check. Okay, so now I tried with the wire initially. So because it's going in a side branch, and I was knowing it that it's going to go in a side branch. So AL1, this is AL1 7 French, parked a routine wire in the side branch so that I know where is that side branch. And then I tried with the filter XT, but it did not simply made any progress. So quickly switched over to Gaia 3, because there were two options in front of me. One was Gaia 3rd or Confianza Pro. So Confianza is a penetrating wire irrespective of whatever comes in between, while Gaia series is an intimal tracking strategy where it will find out and deflect once the calcium comes and try to still maintain inside the lumen. So I thought logically it's a good choice, and it proved to be correct, that on the micro right at the edge, marking the side branch and then trying to penetrate the CTO, I could make some progress. So keeping it there, I went ahead and significantly, the wire has crossed now. It's a big, huge RCA. So I could go well into the PDA, but the issue was coming that the still micro is here only. So the micro catheter is, when I'm trying to take the micro catheter down, everything is prolapsing back. See, this is a micro 7 French AL, but everything is just backing out and nothing is going in. So micro was not growing. So this is a typical lesion where it is not crossable. The wire is crossed, but nothing else is going in. Now at this point of time, we know the reason: calcium, tortuosity, and probably a caravel, which is a more weaker catheter in a calcium or a hard vessel. Now I had three options in front of me. One is, since the 014 wire is crossed, we can take a rotablation wire and then do the rota. Second was Tornus. That's another microcatheter which can make this progress, or opt for a Nick Nano 0.85, because there were a lot of budgetary constraints for this case. So I thought, okay, let me choose the easiest one. That was the Nick Nano 0.85. So to my surprise, in fact, it crossed very easily. As we can see here, there is a marker in the distal lumen. So Nick Nano quite easily crossed it, the CTO, and then rest of the life was easy. Now I just dilated it well with multiple dilatations. Now my micro has crossed easily, and the Grand Slam is in for the next part. So I quickly exchange it over this. Now I took a 2.5 NC balloon. This is a 2.5 NC, given a multiple high pressure dilatations at the CTO segments up and down. And then I thought, okay, I am ready for the case. So this is a stent which is coming in, and stent is not going. As we can see here, it just backing out. There we can see that the AL is backing out. Now, what should be the next strategy? Because a 2.5 NC dilated to 20 atmospheric pressures, and still stent is not going. So at this point of time, I thought, okay, let me go ahead now, since still I was not in a mood to open the rota. So I thought next is OPNC, which is a ultra high pressure balloon. So this is a OPN 2.5 by 15. I dilated multiple dilatations at 40 atmosphere pressure serially, and this is the OPNC, and this is the next cine where the stent just walked in. It's a very good and gratifying to see that the stent has just crossed very easily into the distal segment, well into the distal segment. So then I pulled it back, and yeah, so this is the final case, because then after that again dilated to 3.5, and then this is the final picture where the proximal segment, this is a CTO segment, distal, and then big PD. It's a hyperdominant kind of RCA. So in one case, I had an uncrossable as well as undilatable lesion, which helped both way. And then I could achieve the good final result with the help of Nick Nano as well as the this one. So this quickly I move over to another case. If the time permits, if there are any issues, please let me know. So now after Dr. Arshad case and my RCA case, our eyes are tuned for larger vessels and dominant vessels. Now let's try to see another case of 42-year diabetic male with a typical angina, and these are the vessels. And we know that these are fairly common scenarios still in India, where a 42-year guy with a very bad vessels. See, if we see here, let me freeze. Okay, this is the eleocaudal view. Still, I would like to, and yes, this is a guide which is 7 French. So this is about 2 to 2.25, and we can clearly see all these LAD, LCX, huge 3 branches, but everything is such a smaller than the guide. Diffuse triple vessel disease, and RCA was also similar. So advised for CABG. In view of his age, they were not very keen, and we can see the LAD here. Then this is the eleocaudal view. Again, there is a bifurcation right from the LMCA. LMCA is very short, and then the diffusely disease. Let me go another view. This is the epicranial view. We can see the LMCA, proximal LAD disease, diffuse disease till the distal. So this is the case. I'm very sure many of us will back out at this point of time also, that okay, this looks to be difficult and better to send him with surgery, which is absolutely not a bad option. I agree, but fine, patient wish or also something else. So then I decided to go for a plasty. Then 2 wires were crossed. As we can see here, this is a 1.5 balloon, and I can see the bit of a calcium up, and then there is a tortuous turn. So this is a 1.5 balloon which ruptured. Then I thought, okay, let me take a new balloon. So new balloon, again, that got ruptured and nothing was able to cross this bend. There is a calcified bend here, which was not crossing. So after some deliberation, see here we can see, this is again, after 1.5 multiple ruptures, then I decided that I will take a OPN balloon and dilate it. See, this was even 1.5 was giving a trouble to cross, but a OPN 2.5 did cross. And I gave a good multiple dilatations at 30 to 35 atmospheric pressures, because I was still slightly concerned because the vessel sizes were smaller in this case. But finally, there was a good result. There were a lot of dissections, as we can see here, but OPN did its job, that it did open up the vessel. So the distal was stented. This is the proximal stent. I'll rush through few of the things. Then this was FKI was done, mini crush technique was done, and then the 2 stents were implanted. This is the final picture of the LAD and circumflex. As we can see here, that at the end of procedure, we had a fairly good vessel size, and I could land precisely in this. Yeah, so this is the final picture. This is the circumflex, fairly good filling. Yeah. So this is what was before, and this is what is after. So a good part of this was this calcium bend, and then this sharp bend was there, and that was the thing which was making it undilatable and uncrossable practically. And then the OPNC came at a right time, at a good help, and I could dilate it to a good extent and implant a stent with a fairly good result. Now it's been 9 months. He's doing fine. His RCA was also attempted, and then 2 stents were implanted in RCA also. At the end of 9 months, his TMT is negative at 10.2 mets, and he's enjoying his life. Let's see for how many days, but at least the acute and short-term results are good and acceptable. Then I had another case. It was initially done by my colleague. This is a stent which was implanted for acute inferior wall MI with a cold, means after 7 days of tackling. The issue was, after the stent was implanted, the lady was back within 6 weeks with severe pain again, and this was the check angio, which shows that there is a occlusion here. Now the issue was whether it's a stent thrombosis or whether it's a quick ISR. What must have happened? So I went through all the images carefully with the high resolution. I could see here that there was a big calcium nodule kind of thing, and there it did not expand. Plus there was a strut fracture here. And this had triggered all the events. As we can see here, it's not a thoroughly dilated stent. Plus there is a strut fracture, and there is a dense calcium which was preventing the proper stent apposition. So initially I went ahead with the routine NC balloon, which was given at the high pressure, but still I was not happy as the result. And then I opted for 3.5 by 15 OPN balloon and gave a multiple dilatations at this segment, and then the entire stent segment was dilated. See, now I can see some good expansion. We can easily identify OPNC balloon as compared to any other non-NC because the way it looks and the way the markers are. They're a bit always smaller to make the entry profile smaller. So this was OPNC 3.5/15 at multiple, and the another stent was implanted because there was a strut fracture. So this was the stent which was implanted, and a good post dilatation was given for that also. And this is the final result as we get the 3.5 by balloon, and then this is again a dominant RCA. And now finally, I don't know, can we see the date here? But this is almost a year now, and she has not come back to me, and she's fine. But there was a medial age, which was that calcium spur, which caused that stent fracture and the instant restenosis very early and responsible for the symptoms. So as I can see, this was the IVAS catheter, which I did. So OPN and these balloons are really great addition to our armamentarium. Nic Nano and OPNC, they really come to our rescue when it is needed most. So, and they are safe, as we have seen in this such a smaller vessels. And I put the 2 mm VIVO ISAR in that LCX. And then, so these are the great addition to armamentarium. It saved the rota, as well as the complex procedure, as well as the finances also, because when we practice in a tier 3 city, we have to take care of all these things, and we should come out with the innovative things and what is available, how we can use best to benefit our patients. Thank you very much. If there are any questions and discussions, let's take it.
Yeah, I think there were 3 very, very good cases, and I think we should be able to generate a good amount of discussion on these cases. One thing which you says, the word you use was save rota. I think if you see calcium and, I think of rota first. So I would think, okay, and whenever I do a case and where there's so much of calcium, if I decide to use a rota, my staff is actually very happy that, it's not going to be complex anymore. So I think that is one thing I would like to tell everybody. Especially with when you have we've done so many cases where you had a CTO, you're able to cross and with a wire, but unable to cross with a balloon. So a lot of times you can place your microcatheter right there, and if it's not too tortuous, you can actually push once you had a channel with a Gaia wire or one of these wires, you can actually pass a rota wire at least somewhere down. And then sometimes what we had to do was, if the rota wire, the radiopaque part crosses down, so rotoblade the proximal part, clears out some of the calcium spicules, and then you're actually able to pass the rota wire further down. So that is one. I would have been very happy if you'd use your IVAS for your second case, because they were all very small looking vessels. We really don't know whether they were pseudo small or really small vessels, and for your stent sizing and optimization, I think we would have been much happier to see imaging there. And of course, you did use imaging for your third case, and it was an excellent demonstration of the OPNNC. So I think congratulations on that. Let's get the ball rolling. With somebody, would the chairperson like to say something? Dr. Randeep, I haven't heard from you.
Yes, sir. I'm Dr. Randeep from Apollo Guwahati. Very nicely done cases, sir. Just I wanted to ask one point. In the OPNNC, if there's a calcium spur, actually we had one case in a single calcium spur, we dilated with OPNNC and there is perforation. So have you any case with a single spike, calcium spike and perforation? Because after that we had some issues and we could not pass the graph master.
Yeah, because see, we are dealing with the calcium case and spur, so anything going down is most difficult. But the issue is, like in the first case, that diffuse disease, I had 3 balloons rupture, but unfortunately, fortunately, they were 1.5, 1.5, and 2.5, all ruptured. But I think it gave the way for that OPNC which came up. So it's like a granuloplasty. So that create the way. And OPNC, when you use obviously new, it's a really ultra profile balloons, and they do really cross. So it walked in easily, and the way it dilated that tortuous segment, it straightened out. I'm so far fortunate that after many uses of OPN, I have never had a perforation. But rather than the balloon perforation, the most important thing in OPN is selecting the size. At least select a 0.5 less when you are pre-dilating it, because it's ultra high pressure. Even if it ruptures, it should not reach that force to the walls and cause the vessel perforation. Balloon rupture is fine because it's a double balloon, so it's inherently more safer than the NC balloon, because the barotrauma caused by the NC balloon will be more traumatic to the vessel than the OPN balloon. So the selecting the size is most important. Two, most of the time when we are using a balloon, try to give a parallel wire. That serves two purposes. One, it gives an additional advantage of a high pressure cutting, because that wire will cut the plaque also. So you have a cutting balloon at a higher pressure. Second, because once you deflate these OPNC, they really catch hold of the wire so hard that sometimes it's really difficult to take it out, or it just invariably pulls out the wire. So you have something down in case the wire comes out. So that's why I changed habit after learning from 2-3 cases that okay, that's the way to go ahead. That whenever we are pre-dilating or post-dilating, try to take a parallel wire. But in this case, it was happening that nothing was going in. Like in the first case, Nick Nano, nothing was going in. So there was no question of putting 2 wires. While in the second case, again, nothing was going in. But when I post-dilate or pre-dilate and wire is in, take 2 wires because of the cutting and safety of maintaining the lumen forward. The Nick Nano, this is my 3rd or 4th case of CTO where uncrossable and Nick Nano goes.
Nick Nano
And now I'm fond of that, Nick Nano. Because it saved a lot of hardware and a lot of efforts. Because once wire cross, balloon cross, cardiologist is king.
Dr. Debdatta?
Yeah, sorry, my video is not on for some reasons or the other, but excellent
Your
cases.
voice is crystal clear.
Okay, thankful for that. So I thought in the first case, you used 2 innovative, hardwares given by Translumina. One is Nick Nano, followed by, you said, OPN. I was just wondering what was the stent that you implanted, and that actually brings me to that. Sorry. That actually brings me to the question that we are also here to discuss. I thought any thoughts on what are the deciding factors while we select a stent? Do we really ponder on for a minute or two to actually decide this is the stent I'm going to use in this kind of lesions? Do we really have to choose between stents, given the fact that we always choose hardwares, we plan our lesions like we've chosen Nick Nano and all those? That was one question which was coming in my mind. Had you put in, I'm not certain, had you put in that VIVO ISAR, I think you would have completed the triad of Translumina in that very wonderfully done 20-year CTO of RC.
Yeah, see, unfortunately for that case, I did not put VIVO ISAR because that was too heavily calcified and I needed a more radio opacity to know exactly where my stents are ending. So that's why I did not. But for that diffuse vessel, all those 2 mm stents, they were all VIVO ISR. See, the answer in your question, the answer can be yes and no also. If you dilate the vessel well, prepare the bed well, I think most of the stents will do well. The selection comes when we are using a difficult subsets. Like if we are putting anything across the LMCA and doing a bifurcation, we must know what is the plastic limit and elastic limit of the stent, how much we can stretch and how much diameters we can cross. 2, exact visibility of the stent. 3, like VIVO ISR, I use it in a lot of older patients also. I prefer VIVO ISR because it's the only aluminal coating and a no polymer. So the chance of SAT are extremely less, plus gets endothelized very fast, and invariably they due for something, some dental procedure, some ophthalmic procedure, some cholecystectomy, and then you have to stop everything. So if it's a 1st or 2nd generation stents, we can be in the problem for 1 year not able to stop, DAPT. While these stents will have an advantage that after 2 to 3 months, we can take it off officially, unless the DAPT score is very high. So selecting a stents is always an art, and we must practice it, and we must know each qualities of each stent.
Dr. Sikdar, I haven't heard from you.
One question. For the third case, what was the stent that was originally implanted and what was the stent that you implanted next? How did, because that may have some role, choosing the stent once one stent is there with an ISR. Third stent, what was it?
The first stent was, I think it was a cruise, which was there. And the second stent I implanted was Onyx. In this case, the logic of putting that was, one, the shelf size of 38 was only available in that at that point, because that was done at my colleague center. So that's why the machine was different. But anyway, the reason was, in such a case where there is, a lot of post dilatation and vessel recoil, you need a stent with a very high resistance to recoil. So radial strength of that stent should be very high. So out of that, one is Onyx because of the iridium platform, and another is the Promus series. Again, they are, because platinum chromium, they are the stents with a very good radial strength. Plus the micron size is 81. So that will hold to that, and avoid the vessel recoil. So that's the logic of selecting the stent in that phase. And the excellent radio opacity of Onyx, because precisely there was one stent and I need to put another stent. So I must put it normal to normal. So I must know where is the prior stent, put it before and after, and then select the size. So each case gives us a good clues which stent and what size.
Dr. Ashish from Shelby, Jabalpur. I just want to congratulate you for excellent cases. One. Second, especially about second case. Second case was typical of multivessel calcified disease, and as said, 40% of these are balloon uncrossable, these calcified disease. And very nicely shown that one balloon and second balloon, it is never like that. 1.5 balloon doesn't cross, then OP and NC will not cross. This is a misconception. Initial phase of when you use these OP and NC balloons. So unlike these older NC balloons, which had a higher profile, OP and NC crosses better than your regular balloons. So that's very good. But saying so that we do come across lesions where these OPN will also not cross, but even in those cases, those rota followed by these OPNC will give you the best results.
I would like to stress here, because one is such cases like small cases and all, sometimes, we are really worried, am I using OPN in such a small case? Am I inviting a perforation? So that's the most of the people will have a doubt. But it's my humble suggestion, probably I hope I'm right scientifically and correct, that using a NC balloon and we're using a OPN-NC, OPNC is more safe. It will cause lesser perforations than your routine NC. That's one teaching. Second is, never try to think that I will put a stent and then try to dilate such lesions down the line. They don't yield.
It will never happen.
Whatever we have to do is before. Don't expect even OPNC sometimes to, yield. Like in the second case, OPNC did yield, but sometimes even that doesn't. So preparing the bed is the most important thing. Never take a stent and expect that I will do it later, or it will be more safer after putting a stent and it will prevent my rupture. It won't.
So I've used OPNC in 5 cases, and only one case it was ruptured when the operator, I was assisting that case. So when the operator operated at 45 plus, so that was a little too much, but few people still, OPNC still they go for 40-45. Though the current recommendation says, I think 35 to 40.
Dr. Pranay Jain, I haven't heard from you. Can you have a comment?
Sir, nicely demonstrated cases. I think the best one was the second case, diffusely diseased, a young patient with diffusely diseased vessels, and the end result was excellent, sir. So I was not expecting much of that calcium at the bend, the slight calcium was visible, but I thought that must be an adventitial calcium. But 1.5 mm balloon was also not crossing, and you have demonstrated well how to prepare the bed with 2.5 mm OPN NC and then stented it well, and doing then a bifurcation stenting in such diffusely diseased vessel. And the initial angiogram, the vessel was looking like around 1.5 mm LCX and 2 mm of LED. But the end result, it looked like 3 mm of proximal LED with 2.75 of mid distal junction. So an excellent result with that, sir.
Dr. Sushant, are you there?
Dr. Dilip has to say something.
Yeah, please.
Yeah, actually, I congratulate Patil sir for the nice demonstration of very good cases. Actually, I had a similar case, your second one, a 42-year-old male with a diffuse DVD, diffuse and less caliber. But he had three vessels occlude 100%, LED, LCX, and RV branch. And, and otherwise diffuse triple vessel disease. So I've sent him for the COPD. Second thing, sir, in difficult cases, like crossability is the issue, then we are actually using the telescope guide extension catheter regularly, like telescope guideline, guideliner. So, like in your second case, after dilating the vessel with the 2.5 mm NC balloon, if still you are having the problem with the crossability of the stent, then you can use the telescope. It is a very good guide extension catheter. If it can go down up to the mid segment, then you can take the stent even easily. It makes the thing.
Agreed for that RCA in a guide extension would have helped. But down the line, I feel I'm very happy that I did not use it, because you know that NC gave me the wrong impression that I inflated it and prepared the bed well, and then still did not go. But after OPNC, it just walked like a cake, and that prepared the bed well. See, I would have saved it now, but I invited the later on ISR because of the under expanded stent. But I agree that if it is any deeper segments and the size allowed, all these guide extensions are fantastic helps. And I personally also use it in a lot of cases. It's a great help. All these things.
Thank you. Thank you, sir.
Dr. Reddy, are you still there?
Sir, I think it's excellent cases, but I don't have any experience in OPN in pre-dilating lesions, this kind of lesions. Only I used in calcified lesions and under expanded stents. But this is a new thing, let's say he suggested to take a smaller size balloon, 2.5. What is the lowest is available? 2.5 in these NC balloons? No, this is
0.8, 1.5, 2, 2.5, and then beyond. So 0.8 is Nick Nano.
Okay. I think taking the lowest one and of the dilating gradually upsizing, I think that will be the best. But imaging would certainly will help us how far we can go, stretch. Because it's always scaring to take in a high pressure balloons and small vessels without knowing the size of the vessel.
I mean, yeah, I agree with you. In fact, I've also not been using OPNNC to, pre-dilate lesions with a lot of calcium. Of course, we've had some patients where imaging showed a, ring of calcium at the tightest point. So one has used an OPNNC to pre-dilate. But then I am a major proponent of rotablation. So I would say rota OPN is a great idea. The second case where you had this, the LED, which had a kind of a very sharp acute bend, I would be very cautious in doing a rotablation there. Maybe I'd start with a 1.25 burr to start with if I have to. And whenever you have complex lesions, I think you can start with a smaller burr and go upstream. We have a lot of large plaque burden. You can go in with the 1.25. And if you have had pre-dilatation and unable to dilate, cause a small dissection, again, you can start with a smaller burr. But I think all the cases were very nice. And if anybody has any comments left over, I mean, please free to go ahead. Otherwise, I think we can close the session.
I think again, just to reiterate what Dr. Nikhil Kumar said regarding your second case, that typically exemplifies the coronaries that we tend to encounter in young diabetic smoker subset. I'm not very, I know, I don't remember what was the risk factors in your patient, but we certainly tend to get these patients. And if possible, if available, of course, that imaging certainly helps us to a great extent. What seemed like 2.5 there, as one of our speakers were pointing out, gives us that extra bit of confidence to know that's even more than what is actually seen in the angiogram. And the nature of the calcium can also be adequately dealt with. What is the nature and what plaque modification can be used in sequence? Would it be OPN, rota, OPN, things like that? Means as Dr. Kumar is a very strong proponent of rota, I am actually a very, very strong proponent of imaging. I'm sure all of you are, all of us are. Just only the question of availability that is there.
Yeah, so I think a judicious use of all the armamentarium. I mean, recently we had a case where we had a lady with post CABG and dominant RCA, not grafted for some reason, I don't know why. And she had diffuse calcium in the first part of the RCA, and then again diffuse calcium with a tight lesion in the third part of the RCA. So my plan was to, when the patient came to me with initially with the first angiogram, I said, okay, we'll rotablate the proximal vessel, then replatform it downstream and do the distal vessel, and start with the 1.25 both ways, and then proximal part we'll probably upburr because the distal was not that big to take a bigger burr, maybe maximum 1.5. By the time she came back to us, she had a MI in that territory and ongoing chest pain. RCA was totally occluded with thrombus in the distal. So there now we are at a kind of a big dilemma because rotablation in that kind of a setup would have been dicey. So what we managed to do was wire it with some difficulty. Used a Nic Nano again to create some space in the crux of the RCA. Then took a NC balloon, made some space. We could see flow down now. But then this any balloon which had got inflated, come back, wouldn't cross the first part also. So there what we did was we, great difficulty, made some space with a, NC balloon. Yeah, maybe I could have tried with a OP and NC there, yes. But then once we had some space, with the help of a guideliner, we could put an IVL down, intravascular lithotripsy balloon down the first part. We, shockwaved the first part. Again, post-dilated with the larger NC. Now we have space. Now what we did was we put the guideliner further down and delivered the IVL into the third part. So, gave shockwaves to the third part, dilated third part, and then thereafter things were easy. We stented the distal, stented the proximal, and we were out. So, sometimes, a combination of good hardware. And I think everybody should be, at least cost permitting, have most of them on their shelves, and you don't know what's going to help you out. So I think very nice cases today, and we had a very good discussion on the VIVO ISAR, and I think it's a very promising platform. Good use of adjunctive hardware, and I think very honest and very succinct presentations, and a very, very interesting discussion. So back to you, Ehsan, and thank you so much for having us.
Thank you, the entire panel, the chair, and the moderator, and the speakers of the evening, sir. Thank you. Really made the evening so full of pearl of wisdom. I think would have flown for many of your colleagues who would been listening to this session. And I think, sir, we as a company, sir, stand along with all of you, fight this battle against CABG and also along against calcium. Now, our fight is not against any of the devices. I think our fight is much more holistic today, that we fight calcium. And how do we collaborate with all of you to fight this? And I think we have some wonderful devices in our armamentarium in form of intravascular lithotripsy, which has been a technology, has been a great leveler. In fact, this has really sometime had reduced that barrier of great of many cities of being a great and a small operator many a time. I think this has been a great leveler. I think that made life easy for many of your colleagues, sir. And along with that, we have others devices which really helps your patients that we achieve a polymer-free angioplasty in times to come. Thank you very much, sir, to all you to make it such a wonderful evening. Thanks to all of you. Thanks on behalf of Translumina as we sign off, and the entire audience who's listening to this program.
So just one little thing, I mean, okay, you from your perspective can say fight against CABG. I would like to keep the surgeon on my side.
True, sir.
Right. Thank you so much. Good night, everybody.
Thank you, sir.
Good night. Good night and thank you.
Thank you.